We've all had our blood pressure taken. The cuff wraps around the arm, it squeezes tight, and a minute later, a set of numbers appears. To a clinician, these routine measurements function as a real-time mechanical dashboard, revealing the heart's performance deep inside the chest. The most important gauge on that dashboard is cardiac output. It represents the total volume of blood the heart pumps to the rest of the body in exactly 1 minute. We take the amount of blood squeezed out in a single heartbeat, the stroke volume, and multiply it by the heart rate. For a healthy adult, that typically fills a jug containing 4 to 8 liters of blood every 60 seconds. Calculating this number provides the true horsepower of the body's delivery system. It confirms whether the organs are receiving the fuel they need to maintain basic function. However, 4 to 8 liters is not a universal standard for every patient. A volume that sustains a petite elderly woman would likely lead to organ failure in a large, muscular athlete. To account for this, we use the cardiac index. It divides the raw cardiac output by the patient's body surface area. Regardless of size, the index should always land within a healthy target range of 2.5 to 4.0 liters per minute per square meter. Relying on the cardiac index provides a level of accuracy that raw numbers cannot. It confirms the heart is providing adequate flow for that specific patient's metabolic demands. To manage cardiac output, we have to understand the 3 mechanical forces that control how much blood the heart can move. The split screen shows preload, ventricular stretch before contraction, mirrored by a pulled-back rubber band. It shifts to afterload, the resistance the heart overcomes to eject blood, mirrored by someone pushing a heavy door. Finally, contractility, the squeeze's raw strength, mirrored by a mechanical vise. When cardiac output drops, these 3 pillars help a medical team identify exactly which part of the pump's mechanics has failed. When output falls too low, the body enters a survival state. It diverts blood away from the skin and kidneys to protect the brain. This results in cold, clammy skin, low urine output, and altered mental status, often seen in clinical shock. To catch this early, we can look beyond the minute-by-minute volume and analyze the force of a single heartbeat using the blood pressure reading. This diagram shows a standard blood pressure of 120/80. By subtracting the diastolic number from the systolic, we are left with 40. This value is the pulse pressure. Pulse pressure is an essential indicator because it isolates the physical force the heart generates every time the muscle contracts. A healthy pulse pressure usually sits near 40. If that gap widens beyond 60 or narrows below 25, it indicates a significant change in the patient's condition. Consider a patient with a head injury. You observe their heart rate slowing down and their breathing becoming irregular. As shown on this timeline, the top blood pressure line angles upward while the bottom stays flat, creating a widened pulse pressure. These findings together represent Cushing's triad, a sign of dangerous, increasing pressure inside the skull. Recognizing this widening gap allows a nurse to identify intracranial pressure and alert the surgical team before the brain sustains permanent damage. Now, consider a different scenario. A patient presents with muffled heart sounds and bulging neck veins. This timeline tracks their blood pressure as the systolic and diastolic lines pinch together, creating a narrowed pulse pressure. This is Beck's triad, the hallmark of cardiac tamponade. In this condition, fluid fills the sac around the heart and physically crushes the muscle. This prevents the heart from expanding, which destroys the pillar of preload. The dashboard provides the data necessary to act. By mastering the mechanics of output and pressure, you can identify a failing pump and intervene before these basic vitals reach a terminal state.